I'm delighted to introduce Dr. Paul Sachs, who's the Clinical Director of the Division of Infectious Diseases at Brigham and Women's Hospital, where he holds the Bruce and Robert Beal Distinguished Chair and Professor of Medicine at Harvard Medical School. I would spend time reading his extensive bio, but I'm sure many of you know him already, and we want to save time, so I'm shortening the bios. But welcome to give us the CROI update.
Thank you very much. It is always a delight to come home to New York, both to see my mother and other family, and to stop pretending that I'm not a fan of the New York Yankees, which is something that I have to do in Boston. So here are my disclosures. These are the learning objectives. You can ignore those. I'm just kidding. We have to put learning objectives up, and these are very straightforward. Really what I want you to get out of this presentation is what can you use clinically that we heard about at CROI. So that's what the key updates are all about. One thing I really want to emphasize is that if some of my distinguished co-faculty are covering CROI-related topics in detail, I am going to try and not repeat them. And I also want to say congratulations to Dr. Hsu, who's going to become Chief of Cardiology at UCLA very soon. Congratulations. And I want to, in particular, highlight the fact that this afternoon, Dr. Landovitz is going to be talking about long-acting therapy, and he is going to cover what arguably are the three most important long-acting therapy studies from CROI, this CARES study, the ACDG 5359 Latitude study, and then a prevention study called SEARCH. And in addition, those of you who work in academic medical centers know that last week was Match Day, and I had the pleasure of knowing Dr. Landovitz in 1996 when he matched at Brigham and Women's Hospital, and I have a picture of him right there just to show what he looked like at that time. We both had more hair. Okay. All right. So what am I going to talk about? Well, I always like to look back when CROI's been going on for so long. There have been some CROIs at Denver before, one before, and I have a question for you. What was the big news at the 2006 CROI? That was the last time it was in Denver. Anyone know? You can shout it out. Okay. Anyone remember this study? This is the SMART study. The SMART study of virologic suppression or continuous therapy or drug conservation or intermittent therapy based on your CD4 cell count. And it was presented at that meeting. Remember Steve Deeks running into him in the lobby, and he goes to me, he goes, "You knew what the results were going to be before it was presented, didn't you?" And I said, "No, I didn't." He said, "Of course it doesn't work." But it's hard to believe. At the time, I did not realize it wasn't going to work. There was a lot of concerns about drug toxicity. But I think a close second place for that CROI was the introduction of these drugs, which we now know as darunavir, etravirine, and raltegravir, because the life of our patients with HIV who couldn't achieve virologic suppression was completely transformed shortly after this CROI. And the next 2 years were so exciting because many of the people we followed for a long time became undetectable for the very first time. Really an amazing, amazing advance. So the CROI Convention Center has this giant blue bear right outside the conference center. I had to tell our visitors from other countries that bears in the United States really are not blue. In fact, they're brown or black, and it is quite a sight. But the first thing I'm going to talk about is, even though the most important long-acting studies are going to be summarized by Dr. Landovitz, I'm going to talk about some at CROI. We had two studies that fall into this category of, quote, real-world studies. How well is cabrolpivirine doing in clinical practice? The largest of them found a confirmed virologic failure rate of about 2%, and I've highlighted that in the table. Another one, looking at a little more precise dispensing history, but not as large, found it was at 0.9%. There was one somewhat alarming report from a site in Chicago where they found a virologic failure rate with resistance of 4%. They were concerned that some of the people had received injections at a freestanding injection site and maybe had used bad technique. I'm going to ask you a question now that I'd like you to vote on. Since captopril has now been available for a couple of years, and we have more experience with it, what's been your experience with really the most feared outcome? Have you cared for a person who started this treatment, was adherent to the regimen, was virologic suppressed at baseline, you didn't think they had risk factors for resistance, and they ended up failing with resistance? We know from the clinical trials that the rate is about 1%, 2%, and that's what these real-world studies showed. What has been your experience? Go ahead and tell me, just if you've cared for one. I personally have not yet, but then again, at our site, we only have about 50 people on the treatment. All right. And I just go ahead and advance to get the result. Thank you. Okay. Advance. Okay, so we have 70% are in my camp. They haven't seen one of these cases yet. 8% have. One thing I will say is that the patients who do experience this can obviously achieve virologic suppression on boosted PI-containing regimens, but there are a bunch of reasons why that's suboptimal. So what about a different use of cabrolpivirine? This is the group from UCSF who've been using cabrolpivirine in people who struggle with adherence. They were the first to report this. They've updated their data. And now they have week 48 results to sort of give us some sense of the durability of cabrolpivirine for people with viremia. You can see that 81% are still on this regimen and suppressed. 7 others are suppressed on a modification of a regimen. There were 6 out of 59 who had what were called an adverse virologic outcome. All of them started treatment with advanced HIV disease, and 3 of them are now suppressed on alternative regimens. So it's these data, as well as data from other places, as well as experience from anecdotally from various clinical sites, that prompted us to make this change to the IAS-USA treatment guidelines right before CROI. And that basically the change acknowledges the fact that this is not an FDA-approved use of this combination regimen at all. And in most cases, we would not endorse it. However, we acknowledged, based on these data, based on other data, based on our experience, that there would be some cases where we would do it. And if you have intensive case management for people who struggle with adherence, and they cannot take oral ART consistently, even after trying multiple times, they're at very high risk of HIV disease progression, defined as a CD4 under 200, or previous AIDS defining opportunistic infection, and their virus, importantly, is susceptible to both agents, then we do think this should be strongly considered. And if possible, treatment for concomitant substance use disorder is indicated. Now, going one step forward, remember there are other long-acting injectable drugs that have been approved. Lenacapavir is given twice yearly, and this same group has now published their experience coordinating multiple academic medical centers of their patients with cabotegravir lenacapavir. Now, the most common reason for doing this, of course, is resistance to rilpivirine. And the figure is actually how common NNRTI resistance is globally. And you could see that there's actually quite a lot of it internationally, because obviously efavirenz and nevirapine, first-line ART for many, many years with no virologic monitoring. So that was the most common reason for using it. The most important thing from this case series, which is about to be published, is that the success rate is very high. And now these are not FDA-approved combinations, although if you look at the package insert of lenacapavir, this is an FDA-approved indication. And we have one such individual in our clinical practice who is on lenacapavir and cabotegravir, and she's virologically suppressed, but she has high-level NNRTI resistance and otherwise would not be a candidate for a long-acting injectable ART. So staying with lenacapavir for a moment, this is a subset analysis from the Capella study. The Capella study is basically looking at people who are highly treatment experienced, and you have to put together a new regimen. And lenacapavir is often the most active drug in their new regimen. Some of them had no active drugs. And so looking at this subset of people, 12 people in this study with no other fully active drugs, they still found a virologic suppression rate of 75%, which is encouraging. Now, clearly, it's better to use lenacapavir with active drugs, but if you cannot, as I recently heard about a case, it's better to do this than nothing. Nothing is not a good idea in people with advanced HIV-related immunosuppression. Now, the table is filled with very scary resistance mutations to integrase inhibitors. And I want to emphasize that this subset of people with resistance to integrase inhibitors represents really some of our most difficult to treat people in clinical practice in an era when virtually everyone is virologically suppressed. The ones I worry about the most are people who have integrase inhibitor resistance, which fortunately is still relatively uncommon. May I have a show of hands, please? We're going to have to participate without the help of Slido. Do you have anyone in your clinical practice who has integrase inhibitor resistance? Raise your hand if you do. Yeah, a substantial number. So this is a slowly increasing challenge for us and makes drugs like lenacapavir and fostemsavir particularly important. All right, so to summarize, I just went through the cabopivirine in clinical practice. It's about the same failure rate as you see in clinical trials. In people with viremia, it is promising enough that it has prompted a change in the guidelines, or the guidelines that IAS-USA puts out. We will also successfully combine cabotegravir with lenacapavir if people cannot take rilpivirine. And then lenacapavir can be used sometimes in people with lots of resistance. So now on to other art. Well, my colleague Serena Koenig and her colleagues at Saint-Pierre in Haiti have been doing clinical trials in Haiti for years. And they started this study before COVID, and they took people on second-line regimens of a boosted PI plus nucleosides who were suppressed and said, what will happen if you switch them to bictegravir FTC-TAF? And the reason why that's an open question is because all of the studies of second-line treatment globally pretty much most of them have used dolutegravir, and would bictegravir have the same result? The 48-week results are shown here, and you can see clearly the results are excellent. So even though these are people who we know are going to have lots of NRTI resistance, and we can't measure that resistance, at least not in real time, they still maintain virologic suppression with bictegravir FTC-TAF. Now, fortunately, we are going to be able to go back and get some proviral DNA resistance testing, or archive testing, whoever you want to call it, to confirm that this is a stable enough regimen to use for people with extensive nucleoside resistance. So I want to underscore how difficult this study was to do. I was not on site in Haiti, even though I was a co-investigator in the trial. And so the poster summarized the situation. You know, bictegravir FTC-TAF is non-inferior to continuing PI-based ART, even without resistance testing and in a setting of severe civil unrest. And I want to just highlight how difficult it was to do this study. In fact, the famous doctor, Bill Pop's son during this time period was recently kidnapped. I'm thrilled to say he's been released. But this is a really difficult place to do clinical research, and the fact that they have been able to do it is just remarkable. But back to the results of the study, there's an earlier study called 2SD that was published in the New England Journal of Medicine last year. And 2SD essentially says the same thing. Dolutegravir, lamivudine, and tenofovir together maintain virologic suppression even in people who have extensive NRTI resistance. And I want to say again, like if you look at this, PI drug resistance not assessed but anticipated to be common, you can't assess it in routine clinical practice, and yet they maintain virologic suppression. So we now have 2 prospective clinical trials supporting this decision. So I'm now going to give you a hypothetical case to think through. So you're caring for a patient who's got 6 thymidine-associated mutations, which confers resistance to all NRTIs, and M184V, and K103N, resistance to efavirenz and nevirapine, but not doravirine. And they're on a complex regimen of darunavir cobicistat plus dolutegravir plus doravirine for the last 5 years. And would you feel comfortable now switching them to one of these simpler regimens, bictegravir FTC TAF or dolutegravir lamivudine plus tenofovir or whatever you want, TLD or TAF FTC dolutegravir? Go ahead and let's hear what you think. This is a common scenario where we have people in our practices who are suppressed on complex regimens, and can we just simplify like this? That's the question. So your choices of response are yes, the 2SD and the Haiti study show this should be fine, or B, no, are you out of your mind? Those are your two options. You've got someone with so much resistance, and let's see what you think. Okay, we got people voted. So 70% are willing to switch, and another 27% think I'm out of my mind. Just fine. Okay. One of the big concerns about the global rollout with dolutegravir is that we're going to unleash this massive number of people with dolutegravir resistance. And has that turned out to be true or not? We're starting to see some really good data from Africa, where, by the way, I believe this is correct. I believe that there are right now about 20 million people globally on dolutegravir-based regimens, which is unbelievable if you think about it. Anyway, so what did this study show? It was done in Malawi and Zambia. What it showed is that in those settings where they switched thousands of people to TLD, tenofovir, lamivudine, dolutegravir, that if you're viremic when you make that switch, you're most likely to end up being viremic again, and that's what this figure shows. But of course, that's not so surprising because people are viremic often includes those who aren't taking their medicine so well. The real question is how much resistance occurred? Well, they found some emergent dolutegravir resistance, and we will see some with such a global rollout. But look at this, only 2 with major integrase mutations. That's pretty amazing. And a second study showed something very similar using tenofovir levels as a proxy for adherence. Another study looking at bictegravir FCC TAF for HIV-related tuberculosis. This is a randomized trial of people who typically would have to take dolutegravir twice daily plus tenofovir lamivudine. This is bictegravir FCC TAF twice daily because remember rifampin lowers bictegravir levels, and the primary endpoint is virologic suppression at week 24. And results are very encouraging. So what you see is, 95% suppressed, which is incredibly good, given the fact that in both arms, given the fact that this is active tuberculosis. And they did pharmacokinetic assessments and found that although bictegravir levels were lower, they were still definitely high enough to remain above the target, which is again good news. Whether bictegravir FCC TAF twice daily should be used for treatment of tuberculosis versus the current approach, I'm not sure. Some would argue, well, you're giving too much M-tricytidine, but it's really not a very toxic drug. TAF levels are lowered by rifampin, but intracellular concentrations are high. And this just gives you another option. There are some places in the world where they actually only have one or the other, so it just gives a nice other option. And then one of the more commonly used tests these days is the so-called archive genotype. And I thought this was an interesting study where they did serial testing a bunch of times in people in switch studies. And the results were interesting, to put it mildly. 103 people in this had mutations detected at both time points they checked it. 58 had it just at the first time point, 101 just at the second time point. What this is showing is that this DNA archive test, this proviral DNA, is taking a little sample from your patient's reservoir and trying to assess whether they have resistance, and that has sampling error. This is not something that is going to be consistent over time. So the way to think about this, I think, is basically to think this is a predictive value positive test. If you find resistance, it tells you something. If you don't find resistance, you don't know if there's no resistance there, or is this a sampling error issue? And then the last study, I think, in this section is to use bictegravir FTC TAF for post-exposure prophylaxis. The study design is shown here. Basically, everyone who showed up for non-occupational PEP in this site were offered the chance to switch to bictegravir FTC TAF, and they had a very high rate of completion of the study and of taking all the medications, and then also no seroconversions. Now, the seroconversion rate in post-exposure prophylaxis is so low that we will never have any comparative trial that's going to demonstrate one approach is better than the other. And I think one could argue that this approach is among the best because it's so simple, but this is not currently in the PEP guidelines, but it should be soon. So I don't want to waste time by reading through the summary again, but this will be in your slide handout, so you can sample it for yourself. So what about investigational drugs? We don't have anything quite as exciting as darunavir, etravirine, and raltegravir, but we have some very cool things, including a study that follows up on this paper that was published a few years ago, basically showing that if you give people in care 3 options for long-acting therapy, a single pill once a week, 2 shots in clinic every other month, or implanting or removing 2 plastic rods every 6 months, the most popular choice was once weekly pill. So once weekly pill looks like it may be coming. This is a combination of islatravir, which is not yet approved, plus lenacapavir given orally, not as an injection, compared to continued bictegravir FTC TAF. And the week 24 results were presented. This is a phase 2 study, so small sample size, but nonetheless, it looks very promising. I do want to mention this because it comes up a lot in open label studies. There were more side effects in the people who switched. You can't tell whether those are really side effects or whether this is what's called ascertainment bias, where a person who's switching their therapy from something they previously tolerated well is going to ascribe every symptom to the new treatment. Who knows? We'll have to see. But there is now a planned study, fully powered, of this once-weekly approach. A bunch of other drugs, potentially for once weekly. This drug, 8527, is also being looked at, as Dr. Landovitz will point out, for long-acting PrEP once a month. But there's an integrase inhibitor and a non-nucleoside reverse transcriptase inhibitor, and I do think there's at least energy going forward on this once-weekly approach. And at least anecdotally, when I talk about it with my patients, they seem to like the idea. And then remember that complex case I presented before? Well, keep it in your mind, because this regimen is designed for them. This is bictegravir and lenacapavir. Now, we don't have bictegravir right now, except co-formulated. So this takes bictegravir and lenacapavir separately and is giving them compared to a background complex regimen. And I think you probably know what I mean by complex regimen, but this is the study design's recommendation at the bottom. That's what their complex regimen means. And if you look at what they were taking, not surprisingly, there's a whole host of things. Some of them 3 classes, some of them 2 classes with boosters, some of them with, NNRTI plus boosted PI, et cetera. And the results of this small study show that this bictegravir-lenacapavir combination maintained virologic suppression as well as continuing the complex regimen, which is great. So it looks like it works, and it was very well tolerated. And this is being co-formulated now as a single tablet and will likely get FDA approval if the phase 3 study confirms this early study. So now we're going back to our patient, and now we have bictegravir-lenacapavir available, as I just showed you in this trial. And how would you manage this patient? Well, you can continue them on their currently complex darunavir, dolutegravir, donavirine regimen, or you can switch them to this new 2 active drugs regimen of bictegravir, lenacapavir, which seems very simple, or you could switch them to bictegravir FTC TAF. And your choices are here. See what you think. How come I don't get any music? Thank you. Joan Jett. Okay, let's see. We've got bictegravir lenacapavir has now taken over from bacterial FTC TAF. And I can understand that. 2 active drugs versus partially active nukes and the bictegravir. All right. There's a lot of smart people working on broadly neutralizing antibodies, and a lot of energy going into it, and a lot of research dollars going into it. I have summarized 1, 2, 3, 4, 5 studies on this slide, basically showing that these drugs are not doing much that is going to be useful in the clinic anytime soon. And it's not the first time we've noticed this. This has been going on for a while. And in fact, our pal from across the pond, Laura Waters, wrote this paper, Broadly Neutralizing Antibodies for HIV Treatment, Broad in Theory, Narrow in Reality. The reality is the testing that's required to show your patient has a susceptible virus is costly, and it takes a while. Even if you get adequate levels and the virus is susceptible, people still fail at higher rates than with standard ART. So not ready for prime time is basically my summary on this one. And I know there are people who disagree, and there's scientific interest in BNAbs, and BNAbs is fun to say, and some of the BNAbs are really fun to say, and you're going to hear about 2 of them, which are nicknamed Tab and Zab later today. So my last major section is on complications. And let me start with the complication of the last 5 years or so, which is, or maybe even longer, which is weight gain, and say that there is a population particularly at risk, and that's women. And within that group of people at risk, the group that's at highest risk appears to be those who are either in late perimenopause or menopause. And this is the first time I've seen this particular finding. This is from the WISE study, a prospective cohort study, which includes women with HIV and includes women without HIV. And if you can see, if they're premenopause at the switch to an integrase inhibitor, the weight trajectories are very similar, but not the same in late perimenopause or postmenopausal. There's quite a bit of weight gain. It's weight gain plus increase in waist circumference and body mass index. We still don't have a mechanism, although there was another mouse model of impact of integrase inhibitors on estrogen, the estrogen system, but still not clear. And then what about switching to doravirine? Lots of people tried this in clinical practice, doravirine to non-nuke, replacing an integrase inhibitor. And so enough people have looked at this now that it's been basically, how do I put it? It rose to the level of something that a database analysis could look at it. And you can see from the figure that there was a modest weight loss overall from switching to doravirine-based regimen, particularly in women. But the most of weight loss was seen in people who were not taking TDF at baseline and then were switching to TDF 3TC doravirine. So they're adding TDF to a previous regimen in addition to adding doravirine. So it's hard to really tease apart what the doravirine is doing here when you're adding TDF, because we know from multiple studies that TDF suppresses weight. Which brings me to a study that I'm somewhat embarrassed to be highlighting, but it is interesting. So these 24 individuals with HIV, 12 taking TDF and 12 taking TAF, agreed to undergo upper endoscopy with biopsy. Don't ask me what they were paid to be in this study. I know I would not volunteer for it, but there you go. And you could see that the histologic abnormalities in the TDF patients were significantly more than in the TAF patients. Interestingly, mitochondrial toxicity was evident in both arms. I'm not a pathologist, but I can tell you that there is a difference between these two histologic slides. They also found higher levels of serum intestinal fatty acid binding protein, which is a marker of enterocyte damage. Now, they did this because they had postulated that something in the upper intestine might be the cause of TDF-related weight suppression and lipid lowering. Last, I'm going to mention this very important finding, which is that the leading cause of death right now for people with HIV who are in care is cancer. It's not just AIDS-defining cancers or viral-related cancers, but it is all cancers, and that's this big blue section. This is a paper published in the CID, and my reference is wrong. It's 2024. This is a paper just published, and I definitely want to steer you in the direction of it because it tells you what you may be experiencing in your own patients. This is a real threat to them, as much as certainly way more than AIDS and liver-related deaths, and even more than cardiovascular disease. So I thought this study was interesting and important, just showing that prostate cancer diagnoses were actually occurring later in men with HIV, probably because of reduced screening. So we need to keep this in mind. Now, obviously, the screening for prostate cancer is very controversial, but is indicated in some people, in particular in African-American men, and they are a high proportion in this cohort. So here's my complication summary, and then I'm going to finish up with some quick final lightning round snippets. Another cancer study is that this is a fascinating study from Spain, that there were more people with CD4s less than 200 develop anal cancer, and above 350, it was actually nadir CD4. It was similar to the HIV negative population. Simultaneous treatment of HIV and Hep C. Amazing that we could do that with a 98% SVR rate. I don't know anyone who's done this in clinical practice, but just incredible. One pill for HIV, one pill for hepatitis C. This is a study from China. This new hepatitis B vaccine, way more immunogenic, and really probably should be our preferred vaccine for people, people with HIV who are vaccine non-responders, Heplisav. And then if you have people who have antibodies to hepatitis B core, there is a small risk of hepatitis B reactivation, apparently really only in the people who switch to two-drug regimens that don't have hepatitis B activity. This is really for people who don't have surface antibody. That appears to be the group at highest risk, but it's not common, but it can happen. Something to consider for our caprypyrin switches. And then there's always some nice data on some of these cure efforts, just that there are some babies born to HIV-positive moms who have prolonged remission when they start treatment right away. And then last, this was bizarre. Who knew what a vampire facial was? I didn't. Okay, I didn't. Anyway, this is a report from New Mexico of HIV transmission from vampire facials. And this is the first time I've put Kim Kardashian in any CROI update slide. I guarantee you that. But that's what a vampire facial looks like. So I want to thank some people who helped me with this slide set. In particular, Jean-Michel Molina, Amy Colson, Karam Mounzer, Keith Siegel, Hayden Andrews, and Dr. Lanifitz. Thank you so much. Stay here.
Sit down. Okay. So we already have a ton of questions, but I want to encourage folks, particularly those fellows we had stand up earlier, to come up to the mics. This is an unrivaled opportunity. But I'll start with this. Any work on long-acting injectable ARVs that also cover for Hep B co-infection?
So I think the best answer I can give to that is to point you in the direction of Charlie Flexner's plenary, which he gave at CROI, which was really amazing. It really, he's been a leader in the long-acting antivirals space for years, and he gave a superb overview. I'm not aware of one that has Hep B activity, but maybe he is.
Okay. So how much wiggle room do you expect patients will have in terms of adherence in once-weekly regimens?
It really depends on the regimen. It's a good question. We worry about this. Is missing one dose of your daily pill the same thing as missing one dose of your weekly pill? Probably not. One of the encouraging things about bictegravir is that, like dolutegravir, it has a high resistance barrier. Islatravir theoretically should. So our first regimen, we'll have to see. I think I think this will be popular for some people, not for everybody. We'll take a look. Those of you who of a certain age, remember we used to give once weekly prophylaxis for some OIs.
But could you start a few days late as opposed to missing a dose?
So in long-acting regimens, there's almost always a window around which you have no loss of efficacy.
Why continue BNAB research given multiple failures? You don't have to answer that.
You know what? I just know that scientifically these are fascinating drugs or compounds, but in humans they're not working out so well. One of the presentations was from a colleague of mine who named Afi Sibris, who's a virologist. He's a really smart guy, and when he first saw the in vitro data of what he was studying, which was a tri-specific broadly neutralizing antibody, he was so excited because in the lab it was dynamite, but it barely worked at all. Sorry.
Any concerns about patients who start long-term injectables and then stop without transitioning to oral therapy?
So one of the things we emphasize in anyone who we start on long-acting injectables is the key is to if they feel like they're not going to be able to get their injection, is to either have a supply of oral ART on hand or to contact us immediately. This happened recently with one of our patients who was hospitalized in another state. And he was panicking because it's actually very hard to give cabopivirine to hospitalized patients for a variety of reasons. And I reassured him that he could just resume the oral ART he was taking before. It is theoretically a risk. So far, that has not been the setting in which we're seeing resistance. We're seeing resistance more in people who, for whatever reason, fail, often at least based on the multivariable analysis, because they had unanticipated and an RTI resistance at baseline.
Okay. How do you assess for rilpivirine resistance if you cannot completely trust it? Gene? Okay.
So it's Gene Assure Archive. So the assessing for rilpivirine resistance is best done through a meticulous scanning of their treatment history to see if they've had an RTI failure before, a collection of all the available genotypes that were previously done during a period of viremia, and then cautious interpretation of the Gene Assure Archive with the realization that the predictive value positive of finding a rilpivirine resistance mutation is 100%. The predictive value negative is not 100%. And I do want to also stress that not everyone who has an archive rilpivirine resistance mutation is going to fail, and because the clinical significance of these is uncertain. And you'll see in the CARES study that Rafi will summarize later, this is a surprising finding, is that it was actually not a predictor of failure.
And as big TAF regimens continue to be first-line recommendations, are we seeing any worsening renal function when using these agents?
So remarkably, TAF has turned out to be, as billed, to have very little nephrotoxicity. Now, does that mean when you have a patient who has declining renal function and you send them to your friendly nephrologist, that they then say, oh, continue the TAF, no problem? In fact, they never do, because I can be a nephrologist like they are. They say renal disease is multifactorial. Wasn't that impressive? So since renal disease is multifactorial, they want to remove all the possible factors that could be contributing. So they tell you to stop the tenofovir-based regimen. I understand that, and I do that when I can. But to directly implicate TAF as the cause of someone's renal dysfunction is extremely rare, very, very rare.
How can you get CAB or LENCAB for people with rilpivirine resistance covered? I think that's an insurance.
So yes, it is an insurance challenge. We have been able to do it. We in Boston, Massachusetts, have only been able to obtain rilpivirine, and then we discard the rilpivirine. I am aware that some people have been able to obtain cabotegravir for PrEP and then used it for treatment. I can't make sense of the American healthcare system one way or the other. I'm not alone in that, and so I don't know why we have to get cabopivirine when we just use the cab.
It's broken, that's why. Is there data on Heplisav as 3 doses for people living with HIV?
So the randomized trial that I didn't summarize compared standard hepatitis B vaccine to 2 doses of Heplisav to 3 doses of Heplisav, and both of the Heplisav strategies were superior to the standard Hep B vaccine. The 3-dose group was slightly more immunogenic. What the guidelines are going to do ultimately when they come out and recommend this for non-responders is anyone's guess. I'm actually hopeful they approve the 2-dose strategy, because not all of the protection in hepatitis B vaccine is captured in antibody responses. There's an amnestic response that is still protective. So that's my hope, is that because 2 doses will be certainly easier to do than 3.
Okay, and we have one last question in 30 seconds. Do you start long-acting injectable Cabril if a patient only has K103N?
So I discourage people from going on cabotegravir pivirine with any risk factors for failure, because I don't like the consequences of failure, which is integrase resistance. So even though you can do it based on the package insert and based on the people they enrolled into the clinical trials, I don't encourage it. So does that make sense? And so if unless they're like absolutely dying to go on cabotegravir pivirine and say, I must, I would then say, look, I advise against it, but I think it's certainly better than stopping ART. And I say, let's move forward. There are not that many people who've been on cabopivirine. There weren't that many in the clinical trials who had K103 transmitted at baseline. So.
Okay, well, perfect timing. Thank you very much.
You're welcome.
And do you stay up for the panel?